Okay, so didn't come up with any fancy titles, but I did want to just sort of do a broad overview on neonatal encephalopathy, identify mechanisms or causes of hypoxic ischemic encephalopathy, or HIE as we call it, discuss the criteria for therapeutic hypothermia and where you can find that, because that's important. It doesn't live in my brain either. So um, discuss or demonstrate the understanding of the evaluation for therapeutic hypothermia, including a SARNAT exam, discuss the treatment of seizures, and then review the process of therapeutic hypothermia. Like, what does this look like? And then list possible complications. And then we'll talk briefly about follow-up too. I'd love for you to stop and ask questions as things come up, because I know for a variety of people, this is not something you've ever done or may have ever interfaced with. So if there's any questions I can help answer for you, I'd love to do that. So what I want to talk about is, this is kind of like my soapbox that I get on with my residents typically in the NICU. When we have a baby that's encephalopathic, I don't instantaneously call it hypoxic ischemic encephalopathy, even if they had a birth event that makes me suspicious for that. Because the reason is we just don't know, right? Is their birth event related to like their significant decels or something like that, related to actually an in utero process or another process that's already happening with them, and we're just capturing that on the monitor and we intervened, but it really was a display of the baby's general status. So really what encephalopathy is the same as if we had encephalopathy, it just wouldn't be called neonatal. It's a central nervous system dysfunction. So for babies, of course, who can't talk and explain to us that they're, not well, we have to look at a variety of other things. So we're going to see that they have altered levels of consciousness. They may demonstrate seizures or seizure-like activity, and we'll talk about that a little bit more as we already have. Abnormal tone is a big one, and then abnormal, reflexes like Moro, suck, things like that. Apneas or forgetting to breathe, poor feeding, is one of the few jobs that they have, right? So if we're talking about basic functions plus their feeding, that's something that we can sometimes see. So neonatal encephalopathy may be due to HIE or hypoxic ischemic encephalopathy. It may also be due to inborn errors of metabolism, or other genetic conditions like metabolic or mitochondrial disorders. And then we don't always know the cause before we initiate therapeutic hypothermia. But that's why part of the therapeutic hypothermia sort of casting a wide net for labs includes things that we should think about with metabolic syndromes, like getting an ammonia and a lactate and things like that. So what kinds of things make us concerned or possibly lead to hypoxic ischemic encephalopathy? Obviously, cardiac arrest in the birthing person, that is both a detriment to them and their baby. Hypoxia and or hypotension of the birthing person. So that is something we saw a lot of with COVID, is patients that were hypoxemic and then their babies were in distress. Uterine rupture. We just had a talk recently about uterine window and all sorts of other placental issues. So uterine rupture is one of the things. Placental abruption, as was the case in the case that Sharon presented. Cord prolapse is one of the common things that we see as well. Shoulder dystocia, and then meconium aspiration. And again, this passage of meconium can indicate stress in utero. So it's sort of this, that can also cause you to breathe in your meconium, right? And aspirate that, and then therefore have other problems where you don't transition appropriately after birth. So it's sort of a twofold. You were already stressed and had less reserve, and now you actually aspirated and you're hypoxemic as well from that. Another plug, we've done this a few times and it's on one of our last slides, but this QR code is the Pediatric Clinical Guidelines website. And if you go to, you just specifically select NICU, But and the website is here too if you need to type it in. And I'm sure Sharon can include the links to that. So all you have to do is click on things. But it's a pretty nice resource with a variety of public-facing kind of consensus guidelines where various groups, so some of them are, nephrology, ID, things like that, but also NICU have come together to create things that can be utilized by our community. So in this case, it's neonatal encephalopathy. I think it's actually listed under hypoxic ischemic encephalopathy if you go. So you need to select NICU, then it'd be under neuro. And I believe it's called HIE. Yeah, she put the link in the website for us. So this is what the screenshot of what the top part of that looks like. So I think it's helpful to at least know what you're looking for, because again, like I said, these criteria don't live in my head all the time. So you must fulfill all 3 criteria anytime within 6 hours of birth. And why is the 6 hours piece important? Because time is brain, really, right? So we know that there's ongoing injury and response to that initial first hit. There's a second hit that happens as our body rushes in to try and help this initial, metabolic and cellular insult, and then we cause more injury and damage. So the earlier we can cool, the better. So we would like it to be within 6 hours of birth. We've actually changed our criteria to reflect some of the data that was presented at the Pediatric Academic Society's meeting a couple of years back, where they were showing that babies that were 34 and 35 weeks and cooled really did not do as well. Specifically, the 35-weekers was the group that we were very interested in, because our general criteria used to include 35-weekers. And so those babies had a higher risk of mortality with therapeutic hypothermia. So we've removed that. So we only cool 36 and up weeks. And then looking at objective data, and I have another slide on that. And then the more subjective, slightly SARNAT exam as well. So then we look at the objective data, essentially, did you or did you not have an acute perinatal event? And, acute perinatal events are essentially the things that I listed there before, right? So shoulder dystocia, uterine rupture, cord prolapse, cardiac arrest, profound hypotension or hypoxemia, things like that. And then if you didn't, you have no obvious acute perinatal event. So let's go over what that criteria is. So many of these things are the same. So prolonged resuscitation, APGAR is less than or equal to 5 at 10 minutes of life. And remember, we're doing a 1-minute APGAR, a 5-minute APGAR, and we only go out to 10 if we really haven't scored high enough yet. And this patient met that criteria. So in Sharon's cases, 1, 2, and 5. So we were less than or equal to 5 at 10 minutes of life. They did have prolonged resuscitation, and they were getting positive pressure ventilation, I believe, still at around 10 minutes of life. It looked like they got intubated in the delivery room. So, which makes sense, because as we talked about, we shouldn't be performing chest compressions unless we've kind of moved on to that next, phase of alternative airway. But this is the important piece down here. So if you have an acute perinatal event, we're going to have a slightly lower threshold to cool you, right? So if your pH is less than or equal to 7.1, and ideally this is from your cord gas, but if not, from your baby within 60 minutes of birth. And then if their base deficit is 12 or higher from their cord blood or within the first hour of life. Now, if there's no obvious perinatal event, we're going to make you prove yourself a little bit more, because we just want to make sure we're not cooling kids that just delayed transition or something else, right? So they have a pH criteria of less than or equal to 7 and a base deficit criteria of 16 or higher. I just put this into a table, but it looks slightly different on the document that you'll see on the PCG. I want to spend a little bit of time here, because I think this is one of the most critical things. And this, I want to just say, if you have telemedicine capabilities and you have questions or worries or concerns, like we are happy to sit on telemedicine with you and walk through this exam and help you kind of help us all feel confident that we're seeing the same thing, right? And we agree that this is what it is. So for SARNAT exams, this is what I was saying. I was trying to score our referred patient on, and the way that so our notes, we have this grid in our notes and we highlight, essentially what we saw. That way it's pretty clear, and we try and document the time of the exam, who did the exam, and we try and go back and reassess the patient as well. But you do need to pick their most severe exam. Usually that's the earliest, but not always. So in this case, this patient was somewhere between mild and moderate. I would think, based on the description of this patient being alternating between sleeping and irritability, that they were more like hyper alert and irritable. But normally the typical is not that these babies sleep. So I thought that was an interesting comment. I'm not debating what they saw. It's just not been my usual experience. If they're hyper alert, they tend to stay hyper alert for at least a while you're there. And if they're obtunded, they tend to stay obtunded. So I'm not really entirely clear, but I sort of put this arrow for myself, I drew it between these top two here because I was a little unclear with their exam. But the other criteria, the baby had met on. And then they commented that the activity was normal. The muscle tone is one of the things to really pay attention to. So they commented that it was fairly normal for this baby, but hypotonic would put you in the moderate category. And completely flaccid, is very severe, right? And then going along with a very severe case of neonatal encephalopathy would be a decerebrate posturing. So you are just sort of laying there with your arms straight and your wrists sort of flexed like this. So if you see that, that's really worrisome for that patient. And then we take categories 5 and 6, as the highest scoring thing within that category, if that makes sense. So say that their suck is weak, which would put them in mild because it's not uncoordinated, but then they have an incomplete Moro, you would call them in the moderate category for this, if that makes sense. Does that make sense for everyone here? And then same for, the category 6, where it's going through kind of autonomic functioning with pupils, heart rate, and respiratory rate. If your pupils are constricted, but maybe you're tachycardic and your respiratory rate's normal, I'd say, given the caveat also of did medications impact the what's happening with the pupils, because that's one of the things that we can sometimes see as different medications being administered and they can look different. But if that's not true, then you're going to take the highest category, or they're having apnea, for instance, so they're in the severe category for that. This baby was listed under, that Sharon presented, was listed under their exam as having periodic breathing. They didn't mention the heart rate, but I looked in what they had charted and it was 123, I think I saw, so normal. And then the pupils were constricted. So this would be a moderate category. And the baby had a weak, incomplete Moro and an uncoordinated suck. So they were here in the moderate category. So they were moderate, and then a little unclear on where they landed here, but normally you want 3 in the moderate or severe category totaling to classify as qualifying for pooling. So I guess, what questions do people have about this? Because I feel like this is the thing that providers are going to interface with the most. Does this kind of make sense? Is there anything you feel uncomfortable assessing, like posture or autonomic reflexes or anything else?
So on 5 and 6, even let's say a suck is normal, but then their Moro is exaggerated. It's still classified as mild.
Correct. Yeah. And I think we also have to give the caveat too that under cases of shoulder dystocia, we could have a brachial plexus injury, right? Which may then impact the function of one arm. So if a Moro is incomplete because one arm does the right thing, but the other arm is flaccid, we need to utilize the other categories to help us. That's one of the things that I sort of commonly see that makes it challenging to assess Moro. Clavicular fracture, humeral fracture on occasion, and then brachial plexus injury. Obviously, those babies were quite stuck.
So if they're like, let's say they had a bradycardia because of the morphine. How do you just note it as normal, but then asterisk as, because it wouldn't be moderate. Like let's say morphine
Yeah.
and the bradycardia because the heart rate's in the 60s, which is
You
normal.
mean once they're being cooled already?
Yeah.
Yeah. So once they're being cooled, I think it's harder to assess this. You should go on the most severe one. But yeah, I would say bradycardia is sort of with the asterisk of, this baby's actively cold. So they're going to have a lower, sinus rate, most of the time, at least. But I would say if you have episodes of bradycardia, then that's an unqualified asterisk in my mind. Like you don't need to asterisk that. That's worrisome.
I've always struggled a little bit with spontaneous activity as well because they're never not being touched in those first 2 hours. Fair. And so how do you, when they're not completely obtunded and it's the very severe and they're kind of in that mild moderate, do you ever say okay, can we just give them 5 minutes to settle to see what they're doing? Because a lot of times they're kind of responding to the IV getting put in or
totally, and then you stop touching them and they're
exactly. and then it's well, they're they're responding, but I don't think they're moving normally if they weren't being knocked around.
Great question. Yeah, I would say you have kind of this normal framework in your head, right, of how babies are responding when they're poked, when they're getting an IV, when someone is, sort of trying to calm them down. So I would say that, if they are responding kind of outside of that general norm, that's one thing I use. So, I mean, you go to poke them and they're not, super upset about it. That's certainly somewhat level of consciousness, but they're also not spontaneously, active and working against the stimulus, right? So I think it sort of falls in both for me, but yeah, I definitely have done let's just sort of hands off baby for a few minutes and see what does baby look like, what is baby doing or not. So we have just a little bit better sense.
And then do you ever use the gag instead of the suck? Like if they have a weak suck, but it's there, but they've got a really strong gag, or is that not part of it?
That's not technically part of this, but I, as part of my neurologic exam, am doing that, right? I'm like, okay, you suck. That's fabulous. Or you don't suck. Like, okay. What happens if I gag you? And then I look at that too, because, I think if you have an absent gag, I mean, that's a lot more worrisome to me. I can't imagine a circumstance where you might have a really weak suck and then no gag. Unless there was a specific cranial nerve injury, right? That's the only way that I can explain that going back to medical school. I haven't personally seen that. Doesn't mean that I won't see it the next time I'm on shift. just to school me, right? But yeah, I pretty much am always doing that as part of my neurologic exam, just because I think that's such an important piece of their overall functioning. if you have a baby that doesn't have a gag, I mean, generally those babies are the ones that are apneic, they're decerebrate, they're, comatose. Like you can tell it's incredibly severe. Any other questions about SARNAT? I would just encourage you to document whatever you see, document it. You can kind of copy this online and then put it into your note or utilize this as a note template to kind of say, level of consciousness was blank, this and that, and I would qualify mild, moderate, whatever, just so that if this isn't already a template within your system or within your documentation, that you have something to really refer to it's pretty, what's the word I'm looking for? Like pretty standardized, right? To make sure that we're really meeting all this criteria. Because I think this is the thing that people are always going to go back to is what was the original SARNAT exam, because we expect it will look better over time. And that's part of the therapeutic hypothermia too, for it to look better over time. Okay, I'm going to move on. So seizures, we talked a bit about them already, but let's continue. So they may be really challenging, as we've kind of alluded to. They're often really focal and sometimes really hard to recognize, or you see something and you're like, oh, what's that? It's sort of stopped before I even really got a chance to look at it. So I encourage everyone, if at all possible, to have a video of it that, if you can send, and obviously try and not have any, identifying information for the patient, like an armband or something, if you can avoid it. But if you can't, then I think it's still important to send that to the referring or the transferring facility, because then the accepting facility, because we can really see what that looked like, and also use that as a framework to watch that baby. Because I would expect that if I'm seeing something focal in the right arm, that I'm going to continue seeing that as my area of focus. And I'm not going to start seeing, a left leg bicycle. So I think that can be helpful. You can, as we talked about, can sometimes see this almost like chewing, lip smacking. And people sometimes go, oh, that's so cute, they're trying to suck. And you're like, no, there's nothing near them. Then no one had initiated any rooting, and they're just lip smacking. And that's oftentimes, I feel like when I see lip smacking, it's also got some sort of eye movement, but not always. So eye deviation, helpful to document the directionality of that. If they have nystagmus, which side, that went to. And then bicycling movements, as we mentioned, of the lower extremities. You can have this rhythmic jerking of any extremity, generally not more than one, but sometimes. Apnea, very common to see with seizures. And then, abrupt vital sign changes. So sometimes we'll have a kid that doesn't do much. Maybe they have like a little bit of eye deviation, but their heart rate shoots up and their blood pressure does too. And they're really tachypnic for a brief period of time. And then, and they're not upset. You can't do anything to sort of get them out of it. Suddenly it stops. And then, it may or may not happen again. So I think the more we can document those things and take photos or videos really of those things, that can be helpful. Let me just turn on my light. And then, ideally, before treating, talk to the accepting facility and or neurology if you're in a place that has that. But typically our standard is a phenobarbital load, so 20 milligrams per kilo of phenobarb. Does anyone have questions about seizures? These can be so tricky, I feel like. It's totally clear until a baby's in front of you that you're not sure if they're seizing or not. But that's okay. We've all been there. So passive cooling, kind of a caveat that we should be really careful about passive cooling. Passive cooling can be dangerous in some ways because it can be overshot, where we overcool the babies, or we can undercool them and think that we've kind of started their timeline. So fortunately now on transport, we at UC Davis are able to actively cool. which is great. Our blankets are so much smaller than they used to be. It makes them so much more portable. So that's really helpful. But this is part of our PCG document. So you can go to that website that Sharon had linked and look and see what this documentation says about passive cooling. But essentially, only once the referring facility has, agreed that, yes, we qualify for therapeutic hypothermia. What we do is we attempt to, do this as soon as possible because, again, time is brain. Babies should be naked except for the diaper, and turn off radiant warmers or other things like that, or put them in an open crib. I do think if you can, having the radiant warmer is helpful. Just have the overhead heat turned off. The reason I say that is because you're going to be checking the core rectal temps pretty frequently. And your goal is going to be 33 to 34 degrees. So if you check that and we're falling below, we actually need to put on a tiny bit of heat just to get us to the point where we can kind of maintain that temperature, that core temperature between 33 and 34 degrees. So we want you, if the baby's temperature falls too low, to be checking really frequently every 5 minutes. And then once the core temperature stabilizes, we can check a little less frequently. I think this is a helpful thing to know how to do in the event that you have a baby and maybe you didn't get called initially and it was a little unclear on whether they were encephalopathic. So, I think if we have a delay, it's nice to get the cooling process started. But I think we should all respect passive cooling because we can make babies too high or too low. What can we do during therapeutic hypothermia to really help babies out? Obviously, do our best to maintain, adequate ventilation, oxygenation, and pH. So try and keep those values as normal as possible. Maintain age-appropriate blood pressures. We already know that there was a hit. So if we have these really high blood pressures or really low blood pressures, then, our worry is our cerebral autoregulation is impaired potentially, and then we're impacting an already damaged tissue in that area. Trying to avoid fluid overload. So usually we restrict these babies in terms of fluid quite small for their 3 days while they're being cooled. So usually we do sort of nutritive fluids of about 60 mils per kilo per day, because otherwise we worry about worsening cerebral edema. But sometimes if they have really bad coagulopathy, we just have to do what we have to do, right? And that may mean that they get a variety of blood products or other things. We just need to be smart maybe about the order in which we give those so that we're trying to manage without giving them too much product. And then maintaining normal blood glucoses as much as possible. Sometimes that can be challenging, but I would treat in babies that are on therapeutic hypothermia, I would treat with insulin, but also respecting insulin because it scares me sometimes giving insulin to babies. But typically it's unusual to have high glucoses normally because we're already fluid restricting them, and that means that they're on less dextrose. Their GIRs are small, so their normal blood glucose range is on the lower end. But I would say in really severe cases where they're apneic, they're on a vent, they're decerebrate posturing, your highest utilizer of glucose is your brain, right? So if your brain is not utilizing this, then you actually tend to get higher serum glucoses. So those babies that have high blood sugars, it's a pretty poor prognosis from what I've seen. We should do our best to treat the coagulopathy that we see. Oftentimes babies will have a hypofibrinogenemia, so like their fibrinogen is low. So they may need some cryoprecipitate or some FFP, something to kind of boost them up. Cryo tends to be pretty small volumes though, so that's kind of the caveat for that is you might get more volume if you're worried about acutely the baby needing volume resuscitation because of a placental abruption. Blood and or FFP would be a larger volume. But again, we want to be careful with the volume. So if a baby we believe to be euvolemic and needs correction for coagulopathy, we should make sure to try and minimize that. And then I already mentioned this, but we need to keep in mind that not every encephalopathic baby has hypoxic ischemic encephalopathy, right? So some of them certainly do. They have a really convincing birth story, cord prolapse was witnessed, everything, went the right way, but just the baby was poorly supported during that period of time, no matter, who was holding that cord up. So that's a very different circumstance than a baby that may or may not have been in some degree of extremis for a period of time without a clear indication, and then has low sugars, a lactic acidosis, high, ammonias. Those are babies I'm really worried about a metabolic condition for. So that's why I think it is actually really helpful. And that's part of our protocol to get a lactate ammonia and obviously follow sugars during that initial encephalopathy sort of workup. But then second tier testing of things to think about, talking to genetics, and then getting things like acylcarnitine profile, plasma amino acids, urine organic acids, just not forgetting that every baby isn't a, hypoxic ischemic encephalopathy birth trauma kind of thing. Does that make sense to people? I suspect you all have heard this, that, therapeutic hypothermia in, developed countries is the only proven treatment for neonatal encephalopathy. It improves survival, improves neurodevelopmental outcomes, but unfortunately in lower and middle income countries, there's no apparent benefit. So we're fortunate to live in a developed country that has access to this. But again, we need to be aggressive about getting it started early as much as possible and getting them transferred to a facility that can maintain them on active cooling. You're going to want to maintain core temperatures, as was previously mentioned, between 33 and 34 for 72 hours, and we gradually rewarm them. And again, as we mentioned, a higher risk of seizures is early, and the kids you really hate to see are the kids that didn't quite meet criteria for some reason, and then they seize at 6 hours or 8 hours. You're like, oh God, I just wish that this hadn't happened. I wish that something looked a little bit worse and I had cooled them. So delayed hypothermia is a thing, but it's unclear whether there's benefit. And so I think you have to weigh the risk benefit. And that's where having a conversation with child neurology and, neonatology can be helpful to decide how convinced are we that this was a seizure? How convinced are we that the benefit outweighs the risk for this patient if it doesn't kind of meet the general criteria? It's just like if we were thinking of a patient that's 35 weeks, like now we know, the risk is too high for them. So we wouldn't cool them any longer. And the process, the reason why this works is because it reduces the metabolic rate, it lowers the demand for oxygen and glucose, and allows for cellular healing. It prevents inflammation and apoptosis. We should always talk about the risks of therapies. So as we kind of mentioned, you can have bradycardia. It's sinus bradycardia, but sometimes it's a lot. And you're like, wow, your heart rate's constantly in the 60s. And that feels uncomfortable to look at a lot. Generally, they should be somewhat reactive, just like our babies that have increased vagal tone, or term babies that have increased vagal tone when they're just in newborn nursery, and you go and you listen, you're like, oh, that hurts pretty slow. But then you wake them up enough and they raise their heart rate. So it should be reactive, but it can be alarming for some people, especially if that's the first time you've seen that. We can have thrombocytopenia, especially that worsens with this. And I mentioned coagulopathy. That's not really a part of therapeutic hypothermia, but your coagulation cascade doesn't work as well at colder temperatures. So you may need to treat coagulopathy, more aggressively in some of these patients. And the question is, we don't know. You could have a stroke, for instance, as a cause of, neonatal encephalopathy. And if that's true, then you may have a reason to have, significant coagulopathy or DIC. You can have pulmonary hypertension. And our group has agreed that we would not discontinue therapeutic hypothermia prematurely if the pulmonary hypertension is really bad, and we would actually continue that while on ECMO or ECLS. So there are, I think, some people who have stopped because of significant pulmonary hypertension, but again, then we're risking brain for just, survival, which, we need to talk to families about the risks of all of those things, but you may be incredibly sick and need both treatments. And then this is a picture of subcutaneous fat necrosis. I couldn't find a super great picture. I wish I could remember the name of a patient so I could try and find her pictures, but it's uncommon, but it can happen. This is why we encourage our nurses to reposition patients really frequently. And sometimes, even though you do that, it still happens. But this is days to weeks after therapeutic hypothermia. You can see just this kind of general discoloration, almost bumpiness of that skin. And it can feel like there's some harder nodules underneath. So it's generally benign and self-limited. But in cases where it's extensive, it can cause hypercalcemia and other problems kind of downstream from that. And then what do we do after therapeutic hypothermia? So once babies are rewarmed, so after 72 hours, they get rewarmed over about a 12-hour period. And then at day 4 to 5 of life, we want them to go to MRI of their brain with spectroscopy. And that's been shown to help us predict, neurologic outcomes. I suppose not just adverse, but, help us kind of understand the extent of the injury. Our shift in our center has been to push that earlier, because there was a period, if we get MRIs closer to that 6 to 7 days, we previously said 5 to 7 days was okay. But if we get them in that 6 to 7 day range, there's more evidence now that you can get this sort of pseudo normalization where you're actually missing some of the subtle signs of diffusion restriction and other things like that. So we are trying to push them on the earlier side. And then they'll all have neurodevelopmental follow-up. For us, that's at the Mind Institute. So they'll be seen for 3 visits within the first 3 years. And typically that's the Bayley Scales of Infant and Toddler Development with the 4th edition. But if for some reason they're really impacted developmentally, or that's not an appropriate scale for them, then they will use some other appropriate developmental testing. I think that was it for me. So what questions do you all have? Yeah, go ahead, Donna.
Hi. So I work at a smaller center, and we would be one of the ones that would be like stabilizing the baby to transport to a bigger center like you guys. And every now and then we come across those babies that are just super, like we only do passive cooling, super, super hard to get down to temperature. Yes. They just want to stay a little high. Are we just where we are, document, do what we can and move on? Or should we be doing something additional to help bring it down a little bit?
Yeah, I worry about doing, I've heard people say, oh, well, just, kind of ice them down, put ice near them or on them. Like, I think we know we can cause thermal injury with ice directly on skin, or even ice in a bag on skin. So, I really would avoid that. I think I just have constant communication. Typically when you guys are, when someone's transferring to UC Davis, and certainly if you have to transfer somewhere else, I'm sure there's other people you can contact too. But for us, we'll usually give the provider who we're talking to on the phone our cell phone number, our attending cell phone number, so that if any questions or issues come up. So I think it's just a matter of maximizing skin exposure, right? Ensuring that there's no like sneaky heat source, right? So our old radiant warmers used to have a mattress that was warm. And so if you have one of those, you'd want to make sure that it was completely off. So there was no radiant heat from below, right? Even though the above radiant heat was off. So I think it would make sense to talk on a case by case basis, but definitely document what you've done, and keep checking the temperatures and make sure that we're actually checking rectal temperatures, because sometimes the axillaries are just really not super helpful under those circumstances.